Hello all and welcome to this video lecture on alterations of musculoskeletal function. In this first video, we're really going to start talking about fractures, dislocation and subluxation terms, and some of the support structures within this system. So let's go ahead and get started on fractures. And I will mention that I do have a different video called Module 7, Musculoskeletal Disorders, in which I talk about the fractures and give a lot more examples than I do here, just because we've already kind of covered this. But let's go ahead and get started. So when we say we have a fracture, it's a break in that continuity of the bone. And we can classify it in several different ways, such as complete or incomplete. And in that terminology, we're really talking about if that break went all the way through the bone. So for instance, this one over here would be a complete, whereas something like a green stick fracture, like we see over here, is only partially through the bone. So that would be an incomplete fracture. Then we have our closed or open fracture. And this is really talking about if that bone penetrated skin. So when we have a closed fracture, it means that it has kind of stayed within the lines or the boundaries of the body. So here we see there's no skin that has been penetrated, whereas open, or sometimes we call this a compound fracture, would be when we have a piercing through the skin, or maybe some possible soft tissue trauma taking place. We then have the term comminuted, and this is going to be when we have a fracture that causes the bone to create several different fragments. We're looking for 2 or more fragments, and I don't know that I have the best image of what that looks like on this screen here. Maybe the best example would be segmented, but we would have some other pieces of bone in that area. And then we have the terms linear, oblique, spiral, and transverse. And this is really referencing the orientation of the fracture. So let's start with linear. And I don't have an image of that right here, but if I were to draw one in, it could be more of a vertical line. So let's put one right over here. So that would be a linear fracture. Or sometimes this is found in stress fractures, that in which we're kind of putting so much force in that bone that we get this type of linear fracture here. Oblique we kind of referenced before here, in which it's more of a diagonal in orientation. Spiral fractures is where we have more of a torsion type of break. It's a fracture that curves around the cortices. So remember that our cortical bone is more along the periphery of the bone, and it may become displaced by a twist. So we do see this in a lot of abuse cases, especially when it involves children, where there is something like twisting of the forearm, or it could even be a leg. And then we have transverse, in which it is going to be more along the horizontal plane. And typically we see it moving from one side to the other and being a complete fracture. Then we have this term green stick, which I referenced to earlier when we were talking about an incomplete fracture. And so you want to think about a live green stick, in which if you were to try and snap that in half, we would still have the other portion, the other side, still intact. Then we have a torus fracture. That is going to be when the cortex is going to buckle. So we have an example over here. It's also known as a buckle fracture. And you can't necessarily say that it is a true break, but that cortex, remember the periphery of this bone, is buckling on down. And then what we see right next to that on the right is a bowing fracture. And that usually takes place when the longitudinal force is applied to the bone. And it typically will involve our radius and ulna, or the fibula, and in conjunction the tibia. Then we have a pathologic fracture. And our example of that could be seen over here at D. Now this could be, as far as its orientation, transverse, oblique, or a spiral fracture, but it's weakened by a tumor pressure or just a tumor being present within the area. And as a result, we have a break at the site of a pre-existing abnormality, like we said, a tumor or some other type of abnormality going on within the body. And that force would typically not cause a fracture if the bone was normal. Then we have stress fractures, which I mentioned before, and this is going to occur in normal or abnormal bone that's subjected to repeated forces that could occur in athletics. So for instance, this past year I was training to run the half marathon. I got up to 9 miles and then I started getting severe shin pain. And at first I thought it was shin splints, but then it was not healing and ended up getting an MRI. And luckily it wasn't a true stress fracture, but I had a stress reaction that caused edema to occur in my medullary cavity and within the muscle, the tibialis anterior. So there definitely are some related factors to that repetitive force that was being put on the tibia. And then we have our fatigue fractures that are going to be caused by abnormal stress or torque that's applied to a bone with normal ability to deform and recover. So we see this a lot in joggers, dancers, or our military recruits, and this classifies as a type of stress fracture. And lastly, we have a transchondral fracture. And this is when we are going to have fragmentation and separation of a portion of the articular cartilage that we know is going to be found on the epiphyses or the ends of the bone. And this is going to happen typically in areas like the distal femur, which would be down over here, our ankle, the patella or our kneecap, our olecranon process or the elbow, and our wrist. And we tend to see it happen within adolescence. Now let's talk about how we heal from a fracture. So first we have our direct or primary healing that takes place, and that is going to happen more with surgical fixation that was used to repair the broken bone, most likely put it within alignment if it was misaligned, and we start to get some intramembranous bone formation. And this is straightforward because we have the bone cortices right next to one another, and especially when we have that surgical fixation in place, right? So no callus is going to form in this direct method of bone healing. Now our indirect method, which is known as our secondary method of bone healing, is going to be observed when the fracture is treated with a cast or another non-surgical method, such as using a splint or something like that. So within this type of method, we will see both intramembranous and endochondral bone formation. And if you remember, endochondral bone formation is when we have that bone form due to an underlying cartilage scaffold. And through this process, we are going to get a callus formation. So since I'm already kind of walking through that process, let's reference this image over here. So the first thing that's going to happen is when we break our bone, we are going to get bleeding, right? The bone is very vascular. And so we get a hematoma that is going to form. And then we have an organization to this hematoma. We'll start creating a fibrous network within the area of that break. And our osteoblasts are going to move into the area, and we know that those cells are our bone builders, and we'll start to lengthen some collagen strands and start depositing calcium. That then is going to form this bony callus, and our new bone can be built while we have some other cells, or multinucleated osteoclasts, that will come in and resorb the bone so that we can really remodel the bone to make it the way it was before, and hopefully a little bit stronger so we can prevent a break from taking place there again. So what I'm getting at is that because we have this callus formation, we are going to temporarily have this bone be thicker and denser in this area than it was originally. And then through the remodeling process, this fracture site is then going to reassume its normal shape and strength, and it has adapted to the mechanical stress that has been placed on it. Now, when we have a fracture take place, we of course are going to have some changes, some clinical manifestation, and it could cause unnatural alignment, swelling, muscle spasm, tenderness, pain, impaired sensation, and decreased mobility, and often transient numbness due to nerve trauma. So I want you to think about the position of that broken bone, how it's going to be influenced by muscles pulling at it, gravity being placed on it, and the force of injury. So that numbness is because of the nerve trauma, like we said. But once it fades, that pain can become severe. And the pain can stem from what we discussed, the muscle spasms, the bone misalignment, or soft tissue damage. So what do we do about this? We want to evaluate and treat it. So we can use immobilization with a splint or a cast. That's often enough for fractures that are at least properly aligned. When we have displaced fractures, they are going to require reduction or realignment and immobilization so that we can promote healing. So with closed manipulation or reduction, the bone is going to be realigned manually without surgery and then stabilized with a splint or a cast. When we have traction, we're going to use weights to pull bone fragments into alignment. And this can also be skin traction that would be temporary, or we can use skeletal traction that would be more forceful, maybe using some pins and wires through the bone. And I decided to pop this image in over here so that you can see what this looks like. This is where we have some tibial pins inserted to pull that bone into alignment. Then we have open reduction, which is going to be more of a surgical realignment that would follow internal fixation with hardware like screws or plates. And we can have external fixation, which means we have pins or rods that are placed into the bone and it's connected to an external frame to stabilize the fracture. We can also use bone grafts that can fill bone gaps. They basically take this bone from a cadaver, sterilize it, and put it into the body. Now, there are some complications of poor healing, so we can have something that is a non-union, meaning that the bone ends did not fuse, that then form fibrous tissue, or what we call a false joint. When we have delayed union, that's going to be when the healing is taking longer than 8 to 9 months. And lastly, malunion is when the bone heals in the wrong position. Now to move away from fractures and talk about dislocation and subluxations. So first we have to know the difference between these two terms. When we talk about something that is dislocated, the word I want to pop into your head is that we have a complete, well, really the word is complete. So we have a complete loss of contact between the two joint surfaces. So in this example, we're talking about the femur and the tibia. And down over here, we can see that the humerus has been completely dislocated out of that trochlear notch of the ulna. Whereas with the subluxation, I want you to think of the word partial. This is a partial loss between the contact of the articular surfaces of these bones. So we can see a subluxation of the patella over here, whereas down in the elbow, we see only that partial separation between the humerus and the ulna. And both are usually going to be caused by some type of trauma and are common in people under the age of 20, but usually it'll also be accompanied with a fracture. So like like I said, associated with fractures. We've sometimes got some muscle imbalances or someone with rheumatoid arthritis. Like we said, because it's common in people under 20, it could be like a juvenile rheumatoid arthritis. Not to say that these can't happen in anybody above the age of 20, or some other forms of joint instability. So I want you to also keep in mind some of the more common injuries within children. So that would be like our nursemaid's elbow, in which we have the radial head subluxation. So actually, let me put in an image of that. Here we are. So it is a little bit small. I apologize. And there's my mouse. And so our focus is here and on this annular ligament. It really attaches to our ulna in the anterior and posterior aspects. So it's really forming a ring around the head of the radius. And so if we were to pull a child's hand or wrist, and this typically happens when there's no abuse involved or anything, but we're just swinging a child around so that they can have some fun, right? We might get that subluxation in the elbow. So this can be fixed without too much intervention, but of course you want to go to a clinical practitioner. Typically they're going to place the child's forearm into supination and then kind of push it back so that the head of the radius goes back and is surrounded by the annular ligament. Something else is in adults, we tend to see elbow dislocations with fractures or wrist dislocations from falls, especially when it comes to that foosh injury. And we can also see finger dislocations in contact sports if they're going to catch a football. I actually had this happen in my husband's cousin when he went to go catch a football, but he was 14 years old. And then we have common injuries in the hip and the knee. So in the hip, we do require a bit more force. We typically don't see as much anterior dislocation, but more of a posterior dislocation, especially if we have an MVA, motor vehicle accident. With the knee, this is more prone to dislocation because we're going through some complex motion, and that would happen if we are playing sports. And as you can imagine, with these injuries, we can cause damage to nerves, vessels, ligaments, and other soft tissues around. Nerve damage, such as like if we were to dislocate our shoulder, our axillary nerve may also become damaged, or some of the vessels there. So we might get some avascular necrosis that could take place. And symptoms we would see is pain, swelling, sometimes even joint deformity, and some limited motion taking place. So if we were to have a dislocation or subluxation in the shoulder, we're going to get some severe pain because we do have a lot of nociceptors within that area, and we would be limited in our ability to lift our arm. Our elbow, we may go into more of a protective mode and keep it in the flexed position and resist movement. And with our hip, we will have severe constant pain and might even start adapting to an abnormal leg position or gait. It's actually one of my favorite things to do when I'm walking in the city of Chicago is look at people's gaits and analyze it. And then the last thing I want to mention is evaluation and treatment of this. We can diagnose this pretty easily with a physical exam, and of course further imaging would be supplemental to that. And then we can treat it with reduction, either realigning the joint or keeping it immobilized for about 2 to 6 weeks. And we also want to implement some rehabilitation that would include exercises to help restore some of the range of motion, and the full recovery though may take months to years depending on the severity of it. So here is a question for you. Which term is characteristic for a fracture in which one cortex is perforated and the spongy bone is splintered? So you can see this image over here as an example. If you said D, green stick fracture, you are correct. That is going to perforate one cortex and is going to be splintered through the spongy bone. So the other options, torus fracture, we know that the cortex is going to buckle, but there's not a full break. With our bowing fracture, we're going to see more of a longitudinal force that happens in paired bones, and then we have our spiral fracture that is going to be more of a torsion that encircles the bone. Now let's move into some of our support structures. Now, a lot of people get the word strain and sprain mixed up. So I want you to think, when you see or hear the word strain, you want to think of that T in there, and that should prompt you to think of tendon. So this is a tearing or stretching of the tendon or the muscle. So over here you see an example of that, where we are straining our calcaneal tendon, or let's say our triceps surae or the gastrocnemius muscle here. And just to be clear, our tendons are always attaching muscle to bone, whereas when we talk about a sprain, there's no T in there, right? So we're going to think of the ligament. It's a tear or injury to the ligament. So we can see an example over here, and we know that ligaments are going to connect bone to bone at joints. And so both of these structures are helping to support joint function and can be injured through trauma like tears, lacerations, ruptures, or what we call an avulsion. And this is a complete separation of a tendon or ligament from its bony attachment. And so you could see some of these avulsions taking place over here. This, I can only assume, is our, let's say, our sartorius muscle attaching to the as is. And this could be something like our rectus femoris that is attaching to our AIIS, or anterior inferior iliac spine, and the acetabulum. And we tend to see these avulsions in young athletes just because they are creating so much force or tension within that muscle and tendon. And these can be categorized into first, second, and third degree. I won't go into the details there, but I will mention some of the more common injury sites, such as with our strains, we tend to see them more in the hands, feet, our knee, the upper arm area, our thigh, ankle, and heel, like we see with that Achilles tendon. And with our ligaments, we tend to see that in the upper body as being within our wrist and our elbow, whereas our lower body, it is more of the knee and the ankle. And whenever we have one of these, whether it's a strain, sprain, or avulsion, we of course are going to first trigger inflammation, which is followed by collagen formation to reconnect the torn ends. Now, sometimes we get a misalignment of these collagen formations, and it's something I'm learning a little bit more about. And through rehabilitation, we can cause these collagen fibers to realign more properly. So if they are more of a improper misalignment or improper type of healing, we can get some scar tissue elongation and poor functioning within these areas. And as a patient going through some of this, the symptoms we would have are pain, and it could be sharp and aggravated with movement, or sometimes when we are doing anything that's weight bearing, we get swelling in the area. Some deformity could take place, and definitely some joint instability and reduced function and range of motion. So in order to evaluate and treat this, you want to get it diagnosed through that physical assessment or imaging using something like an X-ray, MRI, or stress tests. And the initial treatment is PRICE. So P is for protection, R is for rest, I is for ice, C is for compression, and E is for elevation. So after this short period where we are supporting with maybe a brace, we do want to follow up with what I mentioned before, doing some rehab or mobilization in order to gain those collagen fibers aligning properly, and also getting that range of motion back. And of course, if we tried all this and it is not getting better, then we would have to turn to surgery or maybe some corticosteroid steroid shots to reduce the pain, but we definitely would want to start repairing some of the torn structures if necessary. So how long does this take? If we have a sprain or strain, it could take more than 3 months to achieve that mechanical stability of the joint. We talked about how it is very painful because we have that soft tissue swelling and changes within that tendon and ligament contour. Our rehab is going to be crucial here to get that functionality back. Next up, we're going to talk about tendinopathy, epicondylopathy, and on the next slide, we'll introduce bursitis. And so these conditions are more due to trauma or overuse, whether we're getting inflammation of the tendon or maybe inflammation of a bursa, which we'll talk about on the next slide, or some of the tendons that attach to the epicondyles in the elbow is the most common. So we can get, like I said, inflammation in that tendon. If it is on that medial epicondyle, this is known as medial epicondylitis, which is known as golf elbow or golfer's elbow. And then we have the tendons that attach to the lateral epicondyle, which is known as lateral epicondylitis, known as tennis elbow. And so the tennis elbow, I'm actually battling this right now, it's been a few months, is more related to the tendons of those extensors in our forearm. Mine started developing because I was trying to go up in heavier weights and my grip just was not there. So I aggravated that tendon. Whereas our medial epicondylitis is more related to the flexors on the anterior forearm. And so what can aggravate this is more of that repetitive use, whether it's flexion or extension, pronation or supination, or maybe an acute injury taking place. And the symptoms that start to develop are more of a localized pain, a tenderness, and weakness, and it worsens with active movements. And as far as the pathophysiology here, we start to get a swelling and thickening of the tendon sheaths that then reduce movement and can cause pain. We can also get some micro tears that can lead to things like bleeding, edema, and possible calcification, in which we would call a calcific tendinitis. And so initially we want to rest and use ice and heat and immobilization. We can use some analgesics or corticosteroid injections if needed. And then let's also talk about bursitis, in which we have an inflammation of the bursa. So just to get you to think about what we learned in anatomy, a bursa is think of it as a purse. That's what the word bursa actually means in Greek. And so we have this sac that is lined with the synovial membrane. And so we've got some synovial fluid within this area, and they're going to be in places like our skin, in between our skin and our bone, or the skin and our muscle and a tendon over bone. And so this could be caused by overuse, or maybe we've got excessive pressure within the area. We can also have things like infection or autoimmune diseases cause the bursitis, and the inflammation that develops within it can cause swelling. And if we have an infection going on, we can get that warmth, redness, and severe pain. So areas where we tend to see this is in the areas like our shoulder, the elbow, which you see pictured over here, over that olecranon process, areas like our hip or the knee, and there are some other areas that are less common. Now, when we have chronic bursitis, that could follow when we have repeated trauma to an area. If we have that inflamed sac, it can also cause inflammation to surrounding tissues. So we want to have early detection and take care of it, because that bursa is going to start to cause pain, it can be either subtle or gradual, and the movement is usually preserved. But when we have certain movements, like let's say the bursitis is in the shoulder, we can have pain when we are abducting or lifting that arm away from our body in the frontal plane. Or if we have the bursitis in the knee, like we have pictured here, we can start to get pain when we're climbing stairs. If it's in the hip, notice if there's pain when you're crossing your legs or laying down on that side. And as individuals get older, they are going to start to have some aches and pains. And so if you're suspecting bursitis, you do want to go in to see a doctor where they're going to take in your history and do a physical exam. And then if necessary, they're going to do an MRI or ultrasound. And to treat it, we want to do some similar things to when we had tendonitis. So resting, using ice and heat and immobilization. We can also use some analgesics. And then what would be different here is we can have some aspiration for the bursitis fluid buildup. So we can use some therapies for that. And we can do our rehabilitation using physical therapy for that post-inflammation to restore if there was any function lost. Next, we're going to discuss myositis ossificans, and this is also known as heterotopic ossification, and this is a late complication of localized muscle injury where we get abnormal bone formation in our soft tissues. And we're not exactly sure about the pathophysiology here, but from the evidence that's been gathered, there's a fundamental cause in the inability of the mesenchymal cells to differentiate into our osteoblastic stem cells. So now we have an inappropriate differentiation of our fibroblasts, which we know are our principal cells of our connective tissue that are supposed to kind of transform into our osteoblasts. And we tend to see this in injuries that are burns, or maybe someone has had joint surgery or has had trauma to the musculoskeletal system or CNS. And because we may be involving muscle or tendons, ligaments, or bones that are near the muscle, we can have some calcification take place that leads to stiffness or deformity of the extremity. And you could see some of these pictured over here where we have some of that calcification over on the lateral aspect of the knee, and over here we're looking at the foot, in which we have that taking place here in the fourth metatarsal, extending over toward the third. Next, let's talk about rhabdomyolysis, and this is when we have a rapid breakdown of our muscle tissue that can lead to the intracellular contents, especially our myoglobin in our bloodstream and also in the extracellular space. So we get something called myoglobin urea, basically meaning there's myoglobin in your urine. And this is a symptom, but it is not always found in rhabdomyolysis. And we can also find some delta lesions, meaning that we have some tears within that sarcolemma membrane. Remember, the membrane around our muscle cells, which allow leakage of the muscle contents. And so we get this triad of manifestations, which include muscle pain, weakness, and dark urine. And so with that, we can get it confused with other related conditions like a crush injury or compartment syndrome, which we're going to talk about in a few slides, or crush syndrome. And we can have some complications arise because of this pathophysiology, such as hyperkalemia from that potassium being released out of the muscle cell. We can also have metabolic acidosis from the phosphorus and the sulfate release. And it can develop into acute renal failure because we have the myoglobin that starts to obstruct our renal tubules. And lastly, we can get DIC, or disseminated intravascular coagulation, which is triggered by all the cellular debris that is actively clotting now. And so a way we can recognize this is most people are going to be alarmed if they have this Coca-Cola urine, that which we can test the urine and see that we have the myoglobinuria. And let's continue this on the next slide here. When we are testing the urine, we also want to do a blood test, and we can see that we have high CK or creatine kinase levels, high potassium and phosphate, along with early hypocalcemia, then followed by late hypercalcemia. And we can also assess renal function, in which we want to definitely make sure to prevent kidney failure from taking place. And so for treatment, our main goal, of course, like we said, is to make sure that we preserve that kidney function, and we want to give rapid IV hydration to maintain perfusion. And if electrolyte imbalance is a big concern, we may also do possible dialysis. Now let's talk about compartment syndrome, which is going to occur when we have increased pressure in a closed muscle compartment. You can see examples of that here in the forearm and also in the leg, where all these muscles and structures are bound by fascia. And so as we have pressure building up in these areas, we're going to compromise things like blood flow, which can lead to ischemia, tissue hypoxia, and necrosis. So let's double click a little bit on some of the stuff I already mentioned. So we talked about how it could be caused by something that is resulting in an increase in pressure within this compartment. So anything that's really disrupting the vascular supply to an extremity. This could be bleeding taking place within the area, edema, inflammation, or maybe there's something else that's decreasing the compartment size. So having a tight cast or bandages or dressings. And then there's other causes too, such as a fracture or a burn. Could be drug overdose or reperfusion injuries, intense exercise, and so forth. And so some of the groups that would be more prone to having this are our hemophilia patients, children with leukemia as well. And so to come back to the pathophysiology, as we have any of those causes leading to increased pressure within the compartment, that stops our capillary blood flow. And that can then lead to edema, which further increases the pressure in that compartment and causes a tamponade effect. That pressure is then causing tissue hypoxia, and we aren't getting enough blood supply to our muscle, and cell death and necrosis can be a result. And so we don't want to have delayed treatment, as that could cause permanent damage or develop into Volkmann ischemic contractor, where we have permanent limb deformity. And so we want to look for clinical signs here. And let me go to the next slide here for our this should actually be our 5 Ps. So that is going to stand for our pain, which is out of proportion to a possible injury that took place here, especially with passive movement, our pallor, and our pulse, or rather pulselessness, which is more of a late sign that we would have. We can also have paresthesia, which is a numbness or tingling, and then of course paralysis or a weakness taking place. And we've talked about what the Volkmann ischemic contractor is. Again, that's a permanent limb deformity that could take place. You can see in these images down here that we do have that forearm pronation, wrist flexion. We also have thumb adduction, and within the metacarpal phalangeal joint, it is first extended. So you can kind of see right in here that extension, and then at the interphalangeal joints, so over here, which we call pip and dip, there's flexion taking place. Now we don't see the elbow here, but the elbow would also be in flexion. As far as diagnosis, it's confirmed by the measurement of the intracompartmental pressure, which is normally less than 10 millimeters mercury, and there is a critical threshold of it being equal or greater to 30 millimeters mercury. And we can measure this using a manometer or electronic transducer. And so if we start nearing that 30 millimeters mercury, we do have to use surgical intervention, which would be a fasciotomy, which relieves the pressure and restores the blood flow to the area. If we do have necrotic tissue, we do want debridement to take place, and we can also utilize skin grafts or vacuum-assisted wound closure. And if we did not intervene with treatment, then we would have delayed treatment as needing amputation. And the last thing to discuss here is malignant hyperthermia. Now, we've talked about this before in previous chapters, but this is a rare life-threatening inherited musculoskeletal disorder that's going to be triggered by certain anesthetics like volatile agents and succinylcholine that leads to hypermetabolic crisis in the skeletal muscle. So the causes of this is of autosomal dominant inheritance, and the most common cause is a mutation within the RYR1 gene. And you could see a representation of that down over here. This is our ryanodine receptor. And we will have some type of anesthetic, usually that's halogenated, and a depolarizing muscle relaxant that can trigger this. This then is going to cause an uncontrolled calcium release from the sarcoplasmic reticulum within the muscle, and that leads to a sustained muscle contraction. We also utilize all of the ATP, so it becomes depleted. We have increased oxygen consumption, which is then going to lead to excessive carbon dioxide production and heat generation, hence the thermogenesis with the temperature rising over here. And so this results in damaging the membrane. We get hyperkalemia, and the myoglobin and creatine kinase is going to release. We are going to see both metabolic and respiratory acidosis, and we get rhabdomyolysis. Since the membrane is damaged, we're allowing the contents inside the skeletal muscle to leak out, and eventually this leads to multi-organ damage and even death if it is untreated. So some other things to look out for is tachycardia, tachypnea, muscle rigidity, especially within the jaw or the masseter muscle, and also having cardiac arrhythmias and dark urine because of that myoglobinuria. So it's important for these patients to know their family history, but even if they're not sure that this runs within their family, they can have a caffeine halothane contractor test, which is really a muscle biopsy, and that serves as a gold standard for the diagnosis of this. And to treat this, we want to stop the triggering agents right away, and we have hyperventilation taking place, but we want 100% oxygen being administered, and we are going to administer dantrolene, which is going to block the calcium release from the sarcoplasmic reticulum, and we can start to cool the patient and correct their acidosis, electrolyte imbalances, hyperkalemia, and end that surgery as soon as possible.